Okay, so thank you for being patient with us. Welcome to Ghana Physicians and Surgeons Foundation educational webinars. Today, we're going to listen to a very, very seasoned speaker who has been a member of our organization for many years in the person of Professor Thelma B. Wright. She's going to be talking about interventional pain procedures for the aging population. My name is Dr. Bertha Ayi, and I'm the moderator for tonight. I'm also the president of the Ghana Physicians and Surgeons Foundation. And just a little bit of trivia. I went to high school with Dr. Thelma Wright, so I've known her for probably over 30 or 40 years. So I'm going to introduce her. Dr. Thelma Wright completed her medical training at the Howard University College of Medicine after having completed her high school education at Wesley Girls High School. She then completed a residency in anesthesiology at the University of Virginia in Charlottesville, where she also did her pain medicine fellowship. She is board certified in anesthesiology and pain medicine, and she's currently the medical director of the University of Maryland Pain Management Institute, and also the program director for the Pain Medicine Fellowship Program. So she knows a lot about pain. Dr. Wright is also an associate professor at the University of Maryland School of Medicine and is a member of various University of Maryland Medical College committees, including the Bioethics Executive Committee, co-chair of UMMS Opioid Stewardship Committee, and the Umbrella Advisory Board. And believe me, if she's program director and medical director of all these organizations and committees, I'm sure there's a lot more she didn't share with us. But it's my pleasure to welcome her to talk about interventional pain procedures. So for the aging population. So Dr. Wright, please.
Thank you. Can you hear me?
Yeah.
You just muted yourself.
Yes, I can hear you very well.
Awesome. Thank you so much for that introduction. And I'm going to try and get through all these slides. I'm not sure whether I can get through all of them, but I will try. So I'm going to be talking about interventional pain procedures for the aging population, but I guess we fall under that category because we all age in here. So I just want to give a disclosure. I have no involvement in any organization with a direct financial interest in what I'm going to be presenting tonight. All right, so who is a pain management specialist? I'm sure most of you know, but I thought there may be some people in the audience who may not know who a pain management specialist is. So according to the American Society of Regional Anesthesia, and wait a minute, I'm not moving through. All right, do you see the slides now?
Yes, it's moving. I can see the screen.
Okay, all right, so because I'm looking at two computers. All right. So according to the American Society of Regional Anesthesia and Pain Medicine, a pain management specialist is a physician with special training in the evaluation, diagnosis, and treatment of pretty much all different types of pain. Now, for the most part, you would get 4 specialties or representation from 4 specialties, and that would be anesthesiology, where I'm coming from, neurology, psychiatry, and physiatry. However, now we have emergency medicine doctors applying for fellowship, family medicine, internal medicine. But for the most part, it's usually these core specialties. All right, so what is pain? And pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So acute pain, for the most part, is usually anywhere from 0 weeks to 4 weeks. That's where acute pain would lie. And then your chronic pain would be anything longer than 3 months, but then you get the subacute, and subacute pain would be anywhere between 4 to 12 weeks. As a chronic pain doctor, I usually would see patients who are in the chronic pain arena. So if you're referring a patient to me and the patient comes and says, my pain just started about a week ago, I'm probably going to send them right back to you because that's acute pain. And primary care physicians should be taking care of that. But then when it lasts longer than 12 weeks, that's when we come in to take care of the patient. All right, so some differences between acute versus chronic pain. So acute pain, usually time limiting, patient had surgery. We know it lasts anywhere from four to 6 weeks. That's your acute pain. We know what the cause is, either surgery, a motor vehicle collision, or, a fall, fracture. Usually when the healing takes place, patient gets better, right? That's the expectation. And then there'll be some signs, blood pressure will go up, heart rate will go up. Versus chronic pain, they have this pain that you can't really pinpoint. It's been around for a while. It's been, now you have different kinds of pain, like, nerve pain, you may have somatic pain. So you have to sort of tease out what's actually going on. And then you have what we call autonomic adaptation, where you don't really have the vitals that are changing. So you don't have the increased blood pressure. You see the patient's blood pressure is fine, heart rate is fine. And at this point, you have this chronic, or what we call persistent pain. Patients who come see us in the chronic pain clinic will probably have an element of both acute and chronic pain. So you have to determine whether it's the acute pain that they're complaining about, or is it the chronic pain that they're complaining about. Next slide here. All right, so what is our goal as pain physicians when we see a patient? So, we like to use a multidisciplinary approach. And when I say multidisciplinary approach, I mean, we don't just do medicines, or we don't just do interventions. We do everything, or we offer the patient the whole gamut. So the goal for our pain patients, or the goal for the doctors who are taking care of the patients who have pain, is to increase physical activity. So it's not to have the patient's pain go down to a pain score of 0. We want to increase function. We want them to go back to work. We want them to increase physical activity. Usually I'll ask a patient, what do you like to do? Some of them will say, I like to golf, I like to cook. And so that's what they want to do. And so we try to get them there, not necessarily to get them to a pain score of 0 out of 10. We want to optimize medication management, especially for the older geriatric patients who have, a lot of medications they're on. We need to look at their medications to make sure we're not adding to the polypharmacy. And then we also trying to make sure that they are able to cope with the pain. You have a lot of patients who come through who have, anxiety, they have depression. So we have 2 pain psychologists actually working in our practice who see these patients to help them with coping skills, behavioral therapy, relaxation, training, and the like. If we're able to eliminate the pain, that's great. But we usually tell patients, our goal is not to give you a pain score of 0, but to make you function, make you go back to work. And if we're able to, we also try not to use, potent medications such as opioids, but rather, do other therapies that are not invasive. I'm kind of going through to computers. All right. So when I say multimodal treatment, what do I mean? So some patients may come to me and I will start them on medications while sending them to physical therapy, occupational therapy, sometimes aqua therapy, which is water therapy. Sometimes I'll offer them a TENS unit, which is a device that I usually use for neuropathic pain. We may offer some interventional therapy, and it's not, I don't do one first and then go to the other. I actually mix it all up. So when you come to see me for the first time, I will probably offer you medication and then maybe physical therapy. I may get an imaging study, and then based on the imaging study, I will decide what injections I will offer. And then, of course, lifestyle changes. You have patients who come through who are obese, BMI high, and they're complaining of back pain. And I will say, you really have to exercise. You have to see a nutritionist to see whether they can help you with weight loss. And then there's some patients who come and say, I don't want any medicines, I don't want any injections. I just want something such as, acupuncture or, Eastern medicine like Reiki, yoga. So I will offer them that also, because there are some pain physicians who don't necessarily do the westernized medicine. They may practice Eastern medicine. All right, so what injections do we offer in the pain practice? The whole gamut. This is definitely not an all-inclusive list, We do epidural injections, and I will talk about the indications for these injections. We do facet block injections, sympathetic blocks. I don't know that I'll go into detail about that. We don't usually get referrals from doctors for sympathetic blocks. So when we see a patient and we determine that they need that, that's when we offer it to them. And then if I have time, I will go into the advanced therapy like spinal cord stimulation, peripheral nerve stimulation, and the like. So why as physicians or pain physicians do we do these injections? So we do the injections because they're therapeutic, right? Patients get some relief from these injections that we do. We also use them as diagnostic tools. There may be a surgeon or neurosurgeon who would want us to do an injection to determine whether their surgery that they're thinking about would work for the patient. So we will do an injection. For instance, if a neurosurgeon sends a patient to me and says, hey, Thelma, can you do an L5 selective nerve root block? Because I'm thinking of doing an L5 laminectomy. I will do that and give them the information that, yeah, the patient got pain relief from that block, and then they may proceed and do their surgery. It's also prognostic. If a patient has cancer and, I'm told that the patient has 6 months to a year, I may offer them a pump, to help them with the pain. It's expected of us, referring physicians expect us to do these injections. Patients would expect that. And of course, the colleagues also expect us to do it. I hate to say that last bullet, but it is a financially viable business model. I have colleagues who only do injections. They don't want to do medications. All they want to do is injections. They don't write for opioids. And, that's their choice. They can choose to do that, but we do the whole gamut. All right. So if you're doing these kind of injections in your practice, you definitely need to have a procedure room. So we have a procedure room. We keep a nurse in there who will give sedation. So that's one of the nice things about coming to an academic center. We do offer patients sedation so they don't, the pain is not as bad as they would experience if they went to another pain practice where there is no sedation given. We also have a radiology tech. There are some practices where the doctor has to actually control the machine themselves. But in our practice, we have a radiology tech who does that. And we also have a table that would carry all sizes, anywhere from, I believe our table would take up to, I think it's 750 pounds. So I get referrals from doctors in the area whose tables will not take, such heavy weights. All right, so what are the causes of back pain? For the most part, it's non-specific in nature, and that's why we as pain physicians don't see patients with acute pain, because for the, most of the time the pain will get better. But if the pain lasts longer than 3 months, that's when, we get concerned, and then, you get concerned and send the patients to a pain physician. All right, so what do we do when these patients show up? We do a complete history. We get a history from the patient. We want to know what their age is, what their medical history is, what kind of surgeries they've had in the past, onset of injury, if any injury was associated with the pain. What are the associated symptoms? Do you have pain shooting down your leg? Is it only in the back? What's going on? Any neurological symptoms? Is it sharp shooting? Do you have any nerve pain? And when I say nerve pain, usually they'll say, I can't feel my feet, it's numb, or the pain is on the lateral aspect of my leg, or, I'm dropping things when I can't open a jar. So you're thinking, okay, there's some neuropathic component to this. You also want to know where the radiation, where is it going? Is it going, I would have patients who say, I have the pain in my back, it's going all the way into my head. And, I usually look at them like, there's no way it can do that. So, sometimes you can tell if the patient is malingering based on what they tell you. And then one thing you want to know is, what are the previous treatments, right? What have they tried before? And sometimes when they come in, they'll tell you, I've tried this, that, and I've tried gabapentin, I've tried Lyrica, I've tried this, and nothing worked. But then if you dig deeper, the doses were not enough, or they did not take it for a long duration of time. So I would ask, how long did you take it? And they say, I took it for 4 days, it didn't work. And I'm like, no, gabapentin, you got to take it for at least a good month before you say it didn't work, or the dose has to be appropriate. So if someone comes to me and says, I took gabapentin 100 milligrams, and I only took it for a week, and the patient is about 75 kilos, that's not going to cut it. So you want to ramp them up. I usually actually titrate them up to side effects. And once they have a side effect, then I scale back. And the huge thing I ask them about is, does the pain stop you from sleeping? And if they say, yes, I keep tossing and turning because of the pain, then I may give them something that will help them with sleep, like nortriptyline or Lyrica. Then, of course, you have to do a physical examination. And if they don't have any imaging studies, that's when you may decide to get an imaging study. And, hopefully the imaging study will correlate with what they're complaining about. All right, so there is also a risk of too many imaging studies or getting confused with imaging studies. So what I usually do when a patient shows up is, first, are there red flags? And what are the red flags? Urinary incontinence, bowel incontinence. They tell you they're falling. That is a red flag and you have to get an MRI. Now, if surgery is being considered, definitely you want to get an imaging study. And if symptoms have been present for more than 4 weeks, that's another reason to get imaging studies. Usually when they get to us, they have an x-ray, but unfortunately, an x-ray wouldn't give you too much information. It just gives you information about bony pathology, whether there's some arthritis, but it wouldn't give you information about nerve compression or disc herniation or infection. So gold standard, you want to get an MRI. If there is a contraindication for an MRI, then you may get a CT with contrast if the patient's kidney function is fine. There have been studies or evidence that shows that, you can take 100 patients who are asymptomatic, and if you get an imaging study, it will show some pathology. So you just have to make sure that when you're treating the patient, you treat the patient, not the imaging study. All right. So what are some of the diagnostic tools we use? So x-rays, like I said before, will give us information about, bony anatomy, whether there's a fracture, whether there's facetothropathy. It wouldn't give you any information about stenosis or nerve compression. You can get a CT if there's contraindication to an MRI, or the patient tells you, I can't sit in an MRI. So, if you have a high index of suspicion for a tumor or fractures, you may want to get a CT, but MRI is the gold standard. It gives you information about bony anatomy, neurological anatomy, and also if there's an infection, disc herniation, MRI would tell you that. EMG nerve conduction study, not as much. I only would get it if the patient is complaining of radicular symptoms, but then the MRI was not very conclusive. So if a patient says, Dr. Wright, I have pain going down my leg, I get an MRI, I can't really tell why the patient is complaining of pain going down their leg. I may send them to neurology to get a nerve conduction study to see whether I can pinpoint what's going on. All right, so this is just a picture of where pain can come from. It can come from, compression of the spinal cord or the nerve roots. It can come from the facet joint where you have arthropathy, or another fancy name for arthritis. It could come from the disc herniating backwards and pressing on the spinal cord or the nerve roots. It could also come from the disc. You can have little tears in the disc, or what we call disc herniation, where it protrudes posteriorly to press on the nerve root. So it could come from a multitude of sources. So you have to determine where the pain is coming from, and of course, you have to correlate it with the MRI. Sorry, I'm moving through to computers. I have my screen and then your screen. All right, so the first topic I'm going to be speaking on is myofascial pain syndrome, and that's very common, especially with patients who do a lot of computer work or IT work, where they're always sitting in front of a computer, sort of, the face stooped forward, and, they're always looking at a computer. They will complain of pain around their neck, usually in the traps, down their neck in the rhomboids, sternocleidomastoid, anywhere in the neck or shoulders. And when you examine them, they will have very sensitive areas. And even if you press, you can actually feel the taut bands of muscle. And, the patient will jump when you press, and we call that the jump sign. And usually, the treatments we use for that would be, over-the-counter medications. We may offer some physical therapy. And mainstay therapy is usually what we call trigger point injections. And that you can do in the office. You don't have to be a pain physician to do that. You can just palpate the areas of the pain and literally put a needle in. You can do dry needling without putting any medication in there. I do not use steroids because of the risk of causing muscle atrophy. So I usually use local anesthetic like bupivacaine, Marcaine, and then put it into the taut bands of muscle. Now, the goal of the trigger point injections is not to cure the pain per se, is really to decrease the pain associated with function. So for instance, if you refer a patient to physical therapy and you've done trigger points for the patient, they're more likely to participate because they don't have as much pain. So that's why we do trigger points. It's no cure by any means. So other treatments like alluded to are the, physical therapy, water therapy. Those are really mainstay therapy. You can offer the patient a TENS unit. Stretching exercises also help. Trigger point injections, like I mentioned before, facilitates participation in physical therapy. Muscle relaxants, NSAIDs, Botox injections. I would use Botox when patient tells me, the trigger point injections with the local anesthetic work. However, they don't last. So they would last anywhere from 2 to 4 weeks. So then I would say, I have Botox, I can inject some Botox. And that may last anywhere from 3 months to even longer. And I do them like 3 months apart because of the risk of antibodies. So Botox injections is also an option. Topical agents like your lidocaine, ointments, Voltaren, diclofenac gel is another medication that helps. And then we also offer things like Cymbalta, because as you already know, is FDA approved for fibromyalgia, and we use it for trigger points. Myofascial pain also. Now I'm going to go into the joints. When older patients come through, usually they have joint pain, from arthritis. And what are some of the treatments? We have a slew of treatments for joint pain. One of them would be to inject the joint space with steroids. We're moving away from that because continued injections into the joint space with steroids actually destroy the cartilage. So now we're using more supplements. I'm going to talk a little bit about hyaluronic acid that we use. It's very effective. Basically what it does is it helps restore like the viscoelasticity in the synovial fluid, helps with movement, decreases inflammation. So we use that quite often. Unfortunately, insurance companies can be a bit, difficult to deal with. They don't want to pay for it. So we have to, get authorization. So my nurse is always on the phone, calling the insurance companies to try to get authorization for the patients. Another I'll say supplementation that we use, or supplements that we use, we do use like carnitine, a mixture of carnitine, serrata extract. And those also have been shown to be quite helpful, gives patients anywhere from 4 weeks to 3 months of pain relief. And then of course, I'll talk a little bit about this genicular nerve block here. All right, next slide. Biologics, I'm sure you guys have heard about that. That has been pretty, it has been well taken by the pain community. Patients do quite well with it. And basically what it does is offer super physiologic amount of growth factors into that joint space, also increases, the cytokines, and then increases the movement and the flexibility in that knee, keeps patients away from surgery. I actually have a family member who was told they were bone on bone, they needed surgery. They had this platelet-rich plasma injected, and they're still fine. They didn't, get the surgery, and I'm glad it didn't. It was sort of a last-ditch effort. I'm like, why don't we try this? And they did, and it worked quite well for them. The thing is, it actually works quite well for lateral epicondylitis, patella tendinopathy, plantar fasciitis. It also helps with that, rotator cuff, and of course, osteoarthritis of the knees and hips. Unfortunately, we haven't really seen much consensus for fracture injuries or sprains. And with the rotator cuff tendinopathy, I don't use it in my practice. There is evidence out there, but I haven't used it. I use it mostly for my knees. patients who come in for knee pain. There is some emerging evidence for low back pain, so we're waiting for the jury to come out about that. All right, so this is just an illustration of how the platelet-rich plasma is obtained. You draw blood from the patient, it's centrifuged, and basically we take the top part off, we centrifuge it again, and then we put it in the joint in question. Patients can get about 3 to 6 months of pain relief, and then they come back and get it done again. And it has become quite popular, and that's what we do quite often in our hospital. All right, next is another treatment for knee pain. I usually will do this for patients who have had knee surgery, like a total knee, continue to have pain, so they have metal in place, or a patient who has had the intra-articular injections with your biologics or your steroids or your, what I just alluded to, the platelet-rich plasma. And basically what it is I block the nerves that supply the joint. So these are sensory nerves, they're not motor. So they're not going to cause some, difficulty in walking after I do it. It's sensory, strictly sensory. And so what we do is block these nerves that supply, that cause, the pain sensation to the knee. And we do a diagnostic block. We block these nerves and see how the patients do. If they have good pain relief, we bring them back and we actually do a radiofrequency ablation. There are 3 different ways we can do that. We can do a pulsed. With a pulsed RFA, we use lower temperatures, about 42 degrees. And the advantage of doing pulse is we don't destroy any structures around the knee. We can also do thermal. When I do thermal, I use a smaller needle tip, so I don't cause a lesion that's too broad to get some of the motor nerves around. So thermal, I may use like a 5mm tip. And then there's also cooled RF. Cooled RF will give a bigger lesion, so we have to be very careful that we don't get other structures when we're doing these ablations. And this can give a patient anywhere from 6 to 12 months of pain relief where they stay away from the surgeon and they don't have to get the replacement if they don't have a replacement already. So this is also quite, very well taken by the pain patients. For the most part, when patients come to me, they've already had the intra-articular injections. So I offer them this injection if they haven't tried it. All right, now we can go to back pain. So we've talked about joints, we've talked about myofascial pain. I'm going to talk a little bit about some of the procedures we do for chronic low back pain. So some patients who see us do not want surgery. They have family members who've had surgery, didn't do very well, so they want to try everything before they consider surgery. So patients will come to see me either for axial back pain or for radicular symptoms, and we have different options for them. Now, if a patient comes to see me and they have red flags, they've tried, injections, they've tried medications, and they continue to have pain, then of course I'm going to send them to surgery. I'm not going to do these injections. But if they don't have any red flags and they've not tried any injections, that's when I will offer them to these patients. All right. So a patient who comes in and says, Dr. Wright, I have pain going down my leg. It's burning, shooting. I have numbness. I fall, or I can't open, a jar, or I feel, tingling my fingers. Of course, I'm going to get an MRI first. And then when I get an MRI and it shows the reason why they have the radicular treatments, I may offer them what we call an epidural, same as what, the females on here. I can't tell who's on here, but if you've been in labor and you've had an epidural, pretty much the same thing. But in our case, we put steroids in the epidural space with some local anesthetic. There are so many different approaches to the epidural space. We can go in the middle, we call it interlaminar, which is what the laboring patients get. Or we can go what we call transforaminal, where we go for the nerve in question, the nerve causing the problem, or we can go caudally, where we go from below because maybe patient has hardware in place and we can't access the epidural space from above. All right, so this is an illustration of a lumbar epidural steroid injection where we go in the middle. This will mostly be for patients who come in with bilateral pain symptoms. They tell you they have pain going down their their left leg and their right leg, or their left arm or their right arm. So with that, I'll go in the middle and just put the medicine there. But if they come to me saying, my pain is only on the right side, or my pain is only on the left side, and you get an MRI and the MRI shows that the pain, the nerve that's in question is, L5 or C6 or C7, then I will go for that particular nerve. I'm not going to do an interlaminar and get the medicine everywhere. All right, so this would be the patient who comes in with pain going down one leg. So with that patient, I will go for what we call a selective nerve root block, where I go for the nerve in question. So for instance, if you look at this picture here, you can see that there's a disc, there's some protrusion of the disc and which is pressing on the nerve. So I'm going to go straight for that nerve and put the steroid around the nerve, and patients should do well. Of course, I would use a little bit of contrast to let me know that I'm in the right spot. And if I'm happy with the picture, then I go ahead and follow it up with some steroids. Sometimes the patient may leave the procedure room with a numb leg because, the local anesthetic would numb everything. And I tell them that, they shouldn't worry, it would get better. And they go home in about, within 4 hours or so, that, they should, the numbness should be better. All right, now what is facetothropathy? So that's a fancy name for arthritis. Basically, it's arthritis. Patients will come in complaining of pain in their back. They will tell, and usually when I'm in the grocery store, I watch these patients, you see them leaning over their cart. That's what I call the grocery cart sign. Or when they're doing their dishes, they're leaning over their sink because, leaning forward makes the pain better. When they extend and lean backwards, the pain is actually worse. So when I'm examining these patients, I sort of lean them back to see whether they'll tell me, oh my God, my pain is worse. Or, and usually they'll come and tell me, my pain is across my back, doesn't really go down my legs. Even if it does go down their legs, it stops at the knee or maybe their calves, but it doesn't go beyond that. If it goes beyond that, then you're thinking, okay, maybe it's radiculopathy. So you have to sort of listen to the patient and determine whether you're dealing with arthritis or you're dealing with radiculopathy, because sometimes you get an MRI, which will show both, right? You get an MRI, which will show multi-level degenerative disc disease. It would also show, disc herniation. It would show lumbar stenosis, but you listen to the patient and correlate it with the MRI finding. All right, so what are some of the symptoms they will present with? They will tell you they have hip pain, they have buttock pain. They will tell you that they have pain with standing or sitting for a long duration of time. They will also tell you they have low back stiffness in the morning, pain during cold weather. They can tell you when it's going to rain. They'll say, I know it's going to rain because my back pain gets worse. Usually don't have paresthesias. They will have pain with extension or lateral rotation, which is what we call facet loading. They will have paraspinous tenderness when you press on their back. They would hurt. And also, if it's really severe, you will see it on MRI. All right, so what do we do with that? Of course, outside of medications and physical therapy,
So,
I
Dr.
will.
I have a quick question for you. So if you
Sure.
could just go back to the spondyloarthropathies. So, historically, some people say they have quote unquote rheumatism. And in their mind, that means when it's cold, their joints will hurt. In retrospect, are these all spondyloarthropathies?
It could be. It could be. I think rheumatism has been used loosely. Yeah, especially where we come from, because we have rheumatoid arthritis, which has to be diagnosed. We got to get the blood work and all that.
Right.
And so, I think it's probably facetothropathy that they call, especially if they tell you, when it's cold, your bones hurt, has to be that. But then you also want to make sure that you're dealing with osteoarthritis and not RA, because the treatments are different. Because as you know, RA, you're going to give some immunomodulators, and the treatment is totally entirely different. So you have to make sure. I don't necessarily send every single patient to a rheumatologist, but if I have a high index of suspicion, I will.
Okay, so for sickle cell patients, it stands to reason that when it's cold, they might sickle and get pain. But for all the others, is there a reason why some joint pain gets worse when it's cold?
Just an element of what their presentation is. When a patient tells me when it's cold, I can tell, my pain gets worse. I'm thinking they have OA. Rheumatoid arthritis, they don't really present like that. They don't complain of pain during cold weather, or they can't tell you it's about to rain. They can't tell you that. And I think it's due to the pressure, right? the pressure, when rain is coming or when it's getting ready to about to rain, they can tell the hydrostatic pressure out there. So usually if they have that complaint, I know it's OA. RA, they don't make those complaints. So with the I can't speak, Facetothropathy or arthritis, outside of physical therapy and medications, there are injections that I do. Some of the injections include doing a diagnostic block. And when I say a diagnostic block, there are these little itty bitty nerves that cause pain to the joints. Like, remember when I did the knee, I showed you the knee genicular nerve blocks that I do. Same thing here. There are these little nerves called the medial branch nerves that cause pain to the facet joint. And what I do is I block those nerves with a little bit of numbing medication, like 0.5 of a cc. And if the patient has pain relief from 0.5 of a cc, then I can safely say that's where the pain is coming from. I bring them back. And once again, we do an ablation, radio frequency ablation. And this is the machine we use. I can do 4 spots at the same time. And basically what I'm doing is I'm zapping those nerves for 90 seconds at about 80 degrees. And the patients will get about 6 to 8 months of pain relief just from that. Patients do quite well with that. And, sometimes I don't see them and they come back and, they get it done again. Now, I used to work closely with this gentleman, orthopedic doctor, who was the sports doctor for, I guess, the sport, the athletes at University of Maryland. So I used to do a lot of facet injection, but for the younger patients, like, your basketball players and your soccer players or your football players, you don't necessarily have to block the nerves and then do a radio frequency ablation. They usually will have inflammation in the joint. And so I can just go into the joint and put some numbing medication and some steroids into the joint because they're younger, their joints are open, and I can go in and do that. But for the older patients, the aging population, the joints are more calcified and I can't, it's harder to get in. So I rather block the nerves and then kill those nerves if I see that that's where the pain is coming from. All right. So the radio frequency ablation is what I talked to you. I mentioned we can give patients about 6 to 12 months of pain relief. And, of course, we add that with physical therapy. And then we also give them some anti-inflammatory or muscle relaxants if they need that. All right. Next is the SI joint pain. What is SI joint pain? It's actually a pain complaints that a lot of doctors, even myself, sometimes I miss. I may think it's arthritis of the back and, I may go and do like a medial branch nerve block thinking I'm going to ablate. I will do the ablation and the patient says, Dr. I didn't get any pain relief, only to find that it was actually the SI joint which was implicated. SI joint is usually below L5, sort of around the butt area, lower than L5, but not in the buttock region. It's sort of up in the right below the L5. And this is the intersection between the sacrum and the ilium. And so we usually go in and put some steroids and local anesthetic in there. Before we do that, we'll send them to physical therapy and we'll give them some home exercises. But I will say, even surgeons have missed SI joint pathology because we never think of it, because we're thinking, oh, maybe it's arthritis, maybe it's this, maybe it's that, and it's SI joint. And that's the simplest pain complaint that you can treat. So if you have an elderly parent who seems to be complaining about their pain and doesn't seem to be upper back, think about SI joint. So usually the pain will be located in the superior medial quadrant of the buttock, inferior to the superior iliac spine, no pain above L5. The thing about SI joint pain is it is quite ubiquitous. It can radiate into the groin, it may radiate into the feet, it can even radiate into the lateral aspect of your leg. So you may think it's neuralgia paresthetica, and it's not even that. So you have to really have a high index of suspicion. Patients, sometimes you go into the room and the patient is pacing. And so you wonder, okay, maybe it's SI joint. Or they'll tell you when I'm in the car, riding in a car, it hurts. And then when they get up and start walking, it actually gets better. they may not complain of any numbness or weakness, but it's this persistent pain. And when you press that area, they will yelp because that's the source of their pain. I've already mentioned this, very underestimated by our surgeons. I have one surgeon who, when they do surgery and the patient is complaining of residual pain, they just say it's SI joint and they send them to me. I'll do an injection to see whether the pain gets better. And sometimes it does get better, and if it does get better, then they will do an SI fusion. All right, so this is just a picture of, an SI joint injection into the joint. I would usually use local and steroids. However, if the patient says, Dr. the pain got better, but it only lasted 2 to 3 weeks, then here again, I can ablate those nerves to give patients longer relief. So I could either do thermal or cooled RF. You just have to be careful about, adjacent structures. And then if that does not last, then they can go to a surgeon and get an SI joint fusion. All right, another syndrome is our Trichotaric bursitis. So Trichotaric bursitis, you would diagnose it when a patient comes in and tells you I have pain on, around my hip, lateral aspect of the thigh. When they lay down, they'll tell you when I lay on that side, it hurts. So they keep turning from side to side when they sleep. You press, it hurts. We usually don't get imaging for that. You palpate. If it causes pain, that's what it is until proven otherwise. And I usually do it blindly. You guys can do it yourselves if you want to do these sort of injections in the office. I think you can do trigger points and you can do Trichotaric bursa injections also. You just palpate and inject. Using an X-ray machine actually confuses things a little bit because unfortunately, there are a lot of bursae covering the greater trochanter. So if you decide to use fluoro or X-ray, you may end up going into the wrong bursa. Because if a patient comes in and their pain is down here and you go injecting this, then you're not going to be helping the patient, right? So I usually just palpate and inject instead of using fluoroscopy. The only time I use fluoroscopy is if the patient is obese and I can't get in blindly, then I may ask the radiology tech to come in so I can use the fluoro machine to get in there. And if you have any questions, Bertha, you can jump in. All right, this is just one slide to say, if you have, anybody with cancer, there are some blocks that we can do for cancer, like a patient with pancreatic cancer or any cancers above the umbilicus. That's my rule of thumb. If it's above the umbilicus, you can do a celiac plexus block. And that would give that cancer patient relief for about 3 months or so. Even patients who drink and have chronic pancreatitis can get a celiac plexus block and they can actually do quite well. Lumbar sympathetic block would be for the patient with lower extremity edema or pain from some cancer where they're now having sort of stasis, and the lumbar sympathetic block would increase the blood flow to that extremity. I would use, once I do a diagnostic block and the patient does well, I may use a neurolytic. So there are, this is a whole lecture in itself, sympathetic block. So I'm not going to dwell on that. However, if all fails, so the patient has gotten everything, they've had the, facet blocks, they've had the epidural, they've had the SI joint injections, they had the trigger points, they've had the Trichotaric bursa injections, and they still continue to complain of pain, we do have some advanced therapies. And by advanced therapies, this is where we put stimulators, electrical stimulators in the patients to stimulate the areas of their pain. So this is advanced therapy, where, if you live in Africa and you come here to try and get this spinal cord stimulation, you need to make sure that there's somebody out there to be able to program it for you if you're losing programming. So, I was actually thinking of introducing it in Ghana, but I kind of changed my mind because, you have to have someone there who can maintain this, right? Because you don't want to put the leads in the patient and they don't have anyone to manage it for them. So that idea actually fell out of my brain pretty quickly. So when I say implantable therapy, what do I mean? So I'm going to be fast here because I know you guys may have some questions. So one, spinal cord stimulation. We have peripheral nerve stimulation. We have intrathecal drug delivery system where we put medications in a pump and put it in the patient so that instead of taking oral opioids, the medication is actually going directly into the central nervous system. And these are patients who tried the oral opioids. They are not getting any pain relief. They are really getting onto the high doses. And we all know the CDC now has guidelines, and we don't want to go over these guidelines. So we may offer an intrathecal pump to put the medication in the pump so that they can get it directly. The good thing about these implantable therapy is they give the patient better analgesia, and they don't have as much side effects as they would if they were taking it orally. Now, not everybody would qualify for these advanced therapies. Patient has to have had, conservative therapy for at least 6 months. And also if they've had surgery in the past, they could be a candidate. If a patient has a pacemaker, it may be a relative contraindication, not absolute, but we're careful when patients have pacemakers, because you don't want a situation where the stimulator, or what I'm talking about, I'm going to talk about a little bit about it, actually interrupts the pacemaker and the pacemaker doesn't work. So when a patient has a pacemaker, I have to think twice before offering them that. If a patient has major psychiatric disorders, I probably will not offer them this. And every patient who I am considering an advanced therapy for has to see a psychologist to be screened for any issues, and they have to also be deemed appropriate for this therapy. And they also should not have any, they shouldn't be suing anybody. So I usually would ask, were you in an accident? Is this workers' comp? Because when I first started doing this years ago, I had one patient I did not know. Actually, I did know, but I was naive. And he was a workers' comp patient. And he, I tried everything. Nothing seemed to work. I did a spinal cord stimulator. And once I got to a point where I wrote a letter and said, okay, they've reached maximum benefit, they came and said, oh, Dr. Wright, I got my money. I think at that time they made like $400K or something. And they told me to take the stimulator out. And I was so upset because I felt like I had been used for the litigation. And once they got it, then, they got their money, they wanted it out. So we also use it for patients like this, patients who have had surgery in the past. They don't have any more surgeries planned because the surgeon is saying, it looks fine, the hardware looks fine, I have nothing else to offer you. I will offer them a spinal cord stimulator. Other indications for a spinal cord stimulator include, patients who've had multiple surgeries now have clumping of the nerve roots. You can't really do much about that clumping of the nerve roots. You can't go and tease it out. So you can offer them a spinal cord stimulator, or like I said, they've had surgery in the past, or they actually have nerve damage, and that can be offered too. Now, what is a spinal cord stimulator? So a spinal cord stimulator involves putting these electrical leads in the patient's epidural space to stimulate the areas of the pain. So we're not taking the pain away per se, we're just replacing the pain with a different sensation, which is more tolerable to the patient. So there's going to be electric currents that goes through the epidural space, goes to the central nervous system, and replaces those painful signals with more tolerable signals, or I would say paresthesias that are more, tolerable to the patient. And basically what we're doing is blocking the pain impulses from getting to the brain. We do a trial first. And if the patient does well with a trial, I do a home trial 5 days. If the patient does well with it, then I put in the implant. I surgically place the stimulator and the implant. And so this is where, you put the lead up in the epidural space. During the trial, there's a rep in the room. They will program the stimulator to cover the areas of the pain with the paresthesias like I was talking about. And they go home for a few days with it. They come back and tell me how they did, and then I implant it. The implantation is done in the operating room. Today I did one actually. Actually, I did two. And, we do them all the time. Patients are surgically implanted, and they do quite well with it. But I'm beginning to see that the pain relief does not last too long. So around 3 years, they start telling me, the pain relief is not the same, and we have to either reprogram or, think of something else. What are some of the complications? Lead migration, the lead could move, the lead could break, infection, epidural hematoma. So you have to be, I'm very, with these patients, I'm very anal when I do these surgeries, I bring them back a week later, 2 weeks later. I mean, I want to make sure that, there's no infection or nothing else that's happened. And, they can't take showers still. I have removed the dressing. So it's because if they get an infection, it's really devastating, and knock on wood, I haven't had an infection in my years of practice. This is just a close-up of a picture where it shows that this is also very helpful for complex regional pain syndrome or neuropathy, like your diabetic neuropathy or peripheral vascular disease. In Europe, they're using this for heart disease like angina. I don't think FDA has approved it here in the States, and that's because they want to make sure someone is getting a heart attack. We actually know they're getting a heart attack, and it's not, we don't have a spinal cord stimulator, which is preventing us from determining that the patient has that. So this was me today. We did a case, 2 cases today, a spinal cord stimulator. This is a patient who had multiple ankle surgeries and was now having sort of a CRPS-like picture where they were having the edema and the allodynia, hyperesthesia. So I did a trial. They did very well. They actually came in after the trial crying, and they wanted the implant. So today we did the implant. And this costs around anywhere from $29,000 to $38,000 for the device. And of course, you have to think of the facility fee and all of that. So it's quite expensive. So you have to have insurance if you're considering this. What else do I have to talk about? Let's see. All right. So peripheral nerve stimulation. So peripheral nerve stimulation is more to do with single nerves, right? So, you have neuralgia paresthetica. So that's what your lateral femoral cutaneous nerve. So you could drop in a lead to cover that area of the pain. So we're doing more and more of that because sometimes the pain may be due to one nerve or 2 nerves. You don't need to go in and stick a whole, spinal cord stimulator in the epidural space. We can just put it around where the nerve is. So if I'm able to localize the nerve in question, then I will do a peripheral nerve stimulator. So for instance, a patient comes in, they've had shingles, now they have postherpetic neuralgia, you've done the intercostal blocks, they continue to have pain, you may consider a peripheral nerve stimulator. You're not going to go for the neuro stimulator, which goes into the epidural space, or a patient who has headaches from occipital neuralgia, that may also be a good reason to do that, or pain following hernia. They've had hernia removal or hernia repair, and they have pain from, around the ilioinguinal nerve or iliohypogastric nerve. You want to just do a peripheral nerve stimulator. So it depends. If you can localize the nerve, then do a peripheral nerve stimulator. If you can't, then go for the spinal cord stimulator, the neuraxial one. And so these are just pictures of how, the nerves that you can potentially use a peripheral nerve stimulator for. I mean, we do it for even suprascapular nerve blocks. I mean, suprascapular neuralgia. Sometimes you have patients who've had a thoracotomy, and whether it was from positioning or what, they now have suprascapular neuralgia. You could do a peripheral nerve peripheral nerve stimulator for that. Of course, you have to do the nerve block first, and if they have relief, then you may consider a peripheral nerve stimulator. Some patients don't want anything external in them, so you could also do an ablation actually on the nerve. So there are times where a patient will come in. I had a patient who was in an accident and had a supraorbital pain. So I did a block, they did well with it, and then I did an ablation. They don't want a stimulator, on top of the eye. They don't want that. So I wouldn't do that for them. But if it's like in the ilioinguinal or intercostal, I could just slide in for a nerve stimulator. And this is same concept like the spinal cord stimulator. You still put the lead in place and you connect it to a generator. And the generator is what gives the impulses to block the nerve or the pain signals, I should say. So this is just a picture of the other indication. So this would be for patients with headaches. Occipital nerve blocks or occipital stimulators have worked quite well for migraine headaches. So a patient comes in for migraines, I may offer them, medications. I may go ahead and offer them Botox injections or some PT. But if all else fails, then I would go to a peripheral nerve stimulator or occipital nerve stimulator, and there has been evidence that it has been helpful for headache pain due to migraine. And this is just a slide to say, it has been quite successful in treating pretty much any kind of pain, whether it's pain in the neck region, in the back, and the chest. Peripheral nerve stimulation has been quite helpful with that. I think I'm about the end of that, and I want to get some questions here because I don't want to just keep talking and then, you guys may have some questions.
Okay. Well, Dr. Wright, thank you so much. This has been amazing. There's some questions.
I was trying to cover everything in a short time so that at least you have a little bit of everything.
But it seems there's so many options for almost every type of pain. I like the buck stops here with me. Like once somebody comes to see you, there's always an option to take away their pain.
Always an option. And, and now, the big thing now is, I don't know who is in there. Is it people here in the States or people in Ghana or everywhere?
Mostly in the States.
Okay, good. I didn't want to turn anyone off. But like now I'm using a lot of medical cannabis. And that has been really pretty impressive. I have patients who come to me, and because of the CDC guidelines, and I've actually, I'm not a big fan of opioids, to be honest. And so when patients come to me and I start an opioid and they want more and more and more, I may just say, nope, let's try some medical cannabis. And they have done quite well with it. So these are patients who take a little bit of opioids and a little bit of medical cannabis, and they're fine. They go back to work. And I think in Maryland, come July, it's going to be recreationally legal. So, now, because now, if I test your urine and it has cannabis in it, I will not write you for opioids, but you have to have a card. And if you have a card, then, so we do all this. And on top of it, we offer medical cannabis too.
Okay. So talking about cannabis, there are some people who like smoke a lot of marijuana every day because they have pain. Is that sort of bioequivalent to medical cannabis?
Well, the only thing is now when a patient comes to see me and I check their urine and they don't have a card and they tell me, well, I smoke it, I get it off the streets, I'm not going to write it because I don't know what's in it. So, because some people will lace it with stuff, with fentanyl, and we hear of people dying from smoking THC because it was laced with fentanyl or whatever have you. So I don't do anything with patients who don't have a card. But if you have a card and I know you go to a dispensary, then, I know, at least I know the doses, it may be 10 milligrams of THC and 5 of, CBD or whatever have you. So I can't call it, and you don't know what you're getting when you're smoking, right? But at least with the edibles, you would know, or even if you're smoking, you would know what you're smoking because the dispensaries will tell you how much is in it. So the amount of THC you're taking.
Okay. All right. So there are a couple of questions. And thank you all for joining us. You've been listening to Dr. Thelma Wright talk about interventional procedures for managing pain in the elderly. And I think the word pain did not come across. So people thought we're going to be talking about interventional procedures in the elderly. And she's talked about the different kinds of modalities and the different injections that she can use. So there's a question from Gifty Ajima who says, when injecting PRP, is the pain relief from the plasma immediate or is it given with local anesthetic?
We don't mix it with local anesthetic, unfortunately. The company do not recommend injecting local anesthetic with it. So the pain relief is about maybe a month, 4 weeks. It's not immediate, no. It's not immediate.
Okay. All right. So thank you for answering that. Her other question was, what is the pathology of SI joint pain and how does surgical fusion improve it?
So, it depends, right? So I think I had a slide that had the different etiologies for SI joint pain. It could come from pregnancy, it could come from trauma, obesity, it could be an accident, it could be from arthritis. So it depends on the etiology. So if the etiology was previous back surgery, and previous back surgery is a big one, Leg length discrepancy is another one. Scoliosis is another one. So you need to know what the etiology of the SI joint pain is to be able to determine whether an SI joint fusion would be helpful. So the patients who benefit from SI joint fusion are the ones who have had surgery in the past, they continue to have, or they've had surgery in the past and now have this residual pain, which is SI related. So fusion would help.
Okay, that sounds good. And I had a question on facetothropathy. So besides the grocery sign where people are leaning forward, is there anything else on exam that will clinically let you know that this patient's pain is not just discitis or something, but this has to do with, um,
So I don't know whether you remember me talking about the facet loading. So there are really three, I won't call it cardinal, but three exam or symptoms and signs, I guess I should say. So a patient will come in and tell you what I told you, my pain is just in the back, across my back. That's classic, across my back, right? It doesn't go down my leg, it's across my back. And they will tell you, when I lean backwards, it hurts. When I lean forward, it hurts. And then when I press around, lateral to the midline, so, around the paraspinous muscles, they will have pain. So very tender when you palpate lateral to the spinous processes. And then you do this maneuver called facet loading, which is an extension and a lateral rotation because you're loading the joints. So I usually bend them backwards and then I laterally rotate them because I'm loading the joints and they will complain of pain. And so those are the three things, just the complaint of sort of mid-back pain that does not radiate, and also the paraspinous tenderness, and then the facet loading. However, there have been times where I would, think a patient has facetothropathy because they had facet loading, they had paraspinous tenderness, and it was good old myofascial pain, muscular pain. So what I may do is I will do trigger point injections first. And if that helps, then great. But if it doesn't, then I go deeper and do facet injections.
Okay, so those were that was my question. I want to ask those who joined us. Dr. Paul Kumafla is the National Secretary, Executive Secretary of GPSF. She joined us. Ms. Joyce Blabo and Dr. Noel Seitutu, I'm assuming is the doctor. If you have any questions, please type them in the chat room or put them in the Q&A section so that Dr. Wright can address it. So while they're thinking, I have a question for you. So for the average physician, I mean, you seem really, really good at this. There's still tons of people who go to their physicians and they don't get sent your way. So what is the disconnect between the primary care, what you're doing, and how are you letting people know that people of your expertise and skill, even
Yeah, I mean, I think that's a great question. I try to do a lot of education. They will invite me to speak, or usually our marketing people would say, hey, do you have any lectures that you can give? And we'll give them a list of lectures. So, we'll go to, family medicine or internal medicine to give lectures to tell them what we do. They also send flyers to the different. So I will say about 90% or maybe 85% of my referrals are internal from the University of Maryland physicians, and the rest will be external. But for the most part, it's internal because they know there are pain physicians there. Now in the community, I would hope that, physicians know about, pain management services, but you're right, some of them don't. And so they keep them. But I think since the CDC guidelines, a lot of the doctors don't want to write opioids anyway. So we're seeing more patients who are coming in because their doctors don't want to write them for opioids. And so we're actually getting a lot of referrals because of that.
All right. Thank you. There's another question. When choosing chronic pain versus general anesthesia, what are the advantages of the fellowship or career for you? Also, is there a high risk of radiation exposure with interventional pain?
I'm going to have to speak for myself. So I went into anesthesia because I wanted to go into pain. Simple as that. I knew I didn't want to go into general anesthesia because I can't wake up at 5:30 every single day for the rest of my life. And, be in the OR by 6 o'clock, 6:30. I'm just not a morning person. So I knew going into anesthesia that I was going to do pain management. Exposure, yes, it depends on how often you're in the procedure room. As I think as an attending, because I'm not there every day, I am there maybe a day or two a week. And, I wear my lead gown. I'm not right in it because, the fellows are doing the cases. I supervise. If I need to go in, I go in. And, you wear the lead gown and, we have the radiation badges. So we're able to tell how much radiation we're getting. And the radiation is really minimal. I think sometimes in the OR, you probably get more radiation, especially if you're in the ortho room, you're getting way more radiation than we do. I mean, we are doing procedures that last anywhere from a minute or less, versus if you're in an ortho case for 3 hours, you may get a bunch of radiation, even though you're back there. So it depends. And then also, like now, I mean, the CA3, or I would say their anesthesia residents who were leaving are not even going into fellowship because they're telling me the kind of offers they're getting. I mean, I'm opening my mouth, and maybe I should go into GA because, general anesthesia, because they're being started off at high. I mean, I've heard 450, I've heard 500 straight out of residency. And I think that's because a lot of the anesthesiologists are retiring. And so now that hole that used to be there has come back. And so now people are being offered so much money just to, come go work. We're losing a lot of our attendings because they're being offered, large sums of money. So I think it depends on when and where you are. Now it's really, it pays quite a lot to go into general anesthesia versus pain. So if you were graduating this year, I would say go into GA because you make a lot of money. But that is if money is your motivation. My money wasn't really my motivation. I like pain management. I like the procedures, and I just didn't want to do GA. I didn't like the fact that there was no continuity of care. And so that's why I went into pain. But you kind of have to decide what you want from what you're doing and then determine whether you want to go into pain or not. I mean, the good news about pain is you can do a little bit of OR, like half and half, 50-50. So you're 50% in the OR, 50% doing pain. The only thing is you end up working more than your colleagues because after your OR, you got to go to the pain clinic and sign notes or answer calls, so that may be a bit difficult. So.
Okay, that sounds good.
Mm-hmm.
Then she also mentioned, is there a high risk of radiation exposure with interventional?
Yeah, I was just mentioning it. We wear lead gowns. I know when I was pregnant, with the lead gown, I also had a sort of a wall, or I don't know what to call it, but it was some kind of shield that we could move, and that was in front of me too. So I wanted to make sure that, I didn't get any, increased exposure, especially being pregnant. So like I said, I think you even get more in the OR than we do because our cases don't last, they usually anywhere from 5 seconds to 30 seconds, nothing long.
Okay. All right. I'm just telling one person that you responded to their question. So they should be on the lookout for it.
Mm-hmm.
All right. Please, any other questions for Dr. Wright?
Kind of late. Maybe no one. It's Friday.
It's Friday. Okay. All right. So this has been very instructive. I put a YouTube link so people can go back and watch it over and over and over again. But thank you so much for your expertise. And, looking from afar, I like the fact that you seem to really enjoy what you're doing.
I do.
I think it's partly because you see the relief it brings. I mean, pain, even when you get a paper cut, it's quite painful. And I'm sure when it's in a joint or your back, it assumes its own degree of mental torture. So
yes, it does. It does. It does, definitely. And I think I see someone ask the question about wondering whether, okay, I think it has to be a combination, really. I don't think any one thing can treat a patient 100%. I mean, some patients think a narcotic is the everything, but no, I think that it has to be combination where you're doing a little bit of everything, like the pharmacological products and, your PT, your injections, acupuncture, that sort of thing. So I wouldn't say one thing would provide relief. I think it has to be everything.
Multifactorial.
Yes, multifactorial. Yep. Of course, you're welcome.
Yes.
All right. You're muted.
Yeah, I've just been informed that it says the chat is disabled.
Oh,
How is the chat disabled? So I'm just gonna type in the chat that people should just type their questions in the Q&A session.
mm-hmm.
I don't know, how is chat disabled? I've
That's
never
interesting.
heard of that one. Okay, I'll say please type your questions.
So is there another platform that this is being
Yeah, it will be on
broadcasted?
YouTube and people will watch it. It's on YouTube.
Gotcha.
Another thing I want to tell people, we'll answer the questions, but if you want to come in and speak, we can let you do that. Just raise your hand and I'll allow you to talk. We just did the webinar format to allow our presenter to go smoothly without interruption and noise. So if you just do a hand raise, I'll let you actually ask. You don't have to type everything. We can let you come in and talk. So I'm gonna ask, okay, so let's see, Dr. Wright, okay, I think we answered that. She said very informative for me as a student.
Oh, thank you.
And I think you responded.
Mm-hmm.
But there are questions. So let's see if people would either raise their hand or Dr. Pearl, I can actually allow her to talk. She doesn't have to show her video or anything.
Mm-hmm.
Let's see, allow to talk.
Okay. Hello.
Yes, go ahead.
Oh, hi. Okay, you guys can hear me. Dr. Wright, thank you
Yes.
so much. This
Of
is
course.
Dr. Pearl Korte Kumapli.
Hi.
Very informative, great for us primary care doctors.
Mm-hmm.
As you know, interventional pain, not everybody has access to interventional pain because not all the cities have interventional pain. So that's to answer Bertha's question about primary care referrals and stuff. But anyway, so my question is, what do you think about alternative medicine modalities such as acupuncture and OMT, osteopathic manipulative treatments, and all those things as also a way to help with pain management?
Yeah. I mean, so normally when a patient comes to see me for the first time, I get the history, or I would say the fellows get the history, or the residents get the history. And, you after talking to them, you kind of get a feel of what they're looking for. I will offer them the different options, like medications. And I think if you remember the slide, I had all the different modalities that we do offer, which includes, what you just mentioned, acupuncture, Eastern medicine. I don't offer chiropractic medicine because I don't know what they do. I'm not, they're not MDs, and we didn't really do that in med school, or we didn't learn that in med school. So when they ask me, what do you think about chiropractor? I say, I don't know, because I would hate to say, go see a chiropractor and something happens and they say, well, Dr. Wright told me to go there and now my neck. So when it comes to chiropractor, I don't, say yes or no. I just say, you may want to do your research and decide whether you think it's going to help you. But everything else I would offer, and you can see, I don't know whether you can see my slide, we offer, complementary and alternative medicine. We actually had an integrative medicine clinic upstairs from where we were, and patients who didn't want to do Western medicine like medications or injections, I would send them over there. But the only problem with that is insurance does not cover. So you have to pay out of pocket. I think now insurance is paying for acupuncture, but it's just a few of them. For the most part, most patients have to pay out of pocket. So with those alternative therapies, if insurance doesn't pay for it, patients don't want to do it.
That's so true. Yes. Thank you so much.
Of course, of course. Any other questions? You muted it. I think, Gifty, you're muted, Bertha.
Yeah, good evening, Dr.
Oh,
Um,
I was muted, sorry.
Oh. I'm Gifty. I'm one of the CA1s at Hopkins, and
Okay.
I'm interested in chronic pain.
Mm.
I'm curious as to what the temperature is like for chronic pain interventions in Ghana. I know you had mentioned maybe wanting to do the spinal cord stimulators, but not quite. But what sort of things can be done from those of us who trained here who want to get involved back home in this field?
Yeah, I know I think Kolebu has sort of a pain service. I know they had called me to come there and help them with the acute pain service. I don't know what happened with that, but I went and I wrote a 10-page report and got it back to them, and they said, we don't have money to do all this. So, but I think they have a new hospital, Kolebu, near like the Legon area. Have you been to that one, Bertha? It was a beautiful center, and I'm actually thinking of talking to them about, potentially going there like every 3 months or so to do sort of epidurals and facet injections, the bread and butter stuff. I think with the advanced therapies, we're not there yet because you have to be able to get the reps over there, like, the Medtronic or the, Boston Scientific. So I think that's going to take a little while. But with the facet injections and the epidurals and the SI joints, I think that there's definitely a role there, and we could potentially do that. But I haven't really been serious till now because I've been busy. But now I think that I'm ready to go back. Actually, someone had gifted me a radio frequency ablation machine, which I have in my basement, never been used, brand new with all the needles. And I'm thinking I may take it to Ghana and use it there because it's been sitting in my basement for a while. But I think that would be for the ablation where I actually burn the nerves either in the knee or in the back. And I think because people travel to the States, to South Africa for treatment, why not just go to Ghana and do it there and have people
Right.
come there?
Oh, please send it to Ghana. We need it. We need it the most.
I will. I'll send it and use it, sure. I will. I'm actually thinking about it. I just have to carry it the next time I go to Ghana and make sure that I can find something, a step down or step up or whatever to make sure it doesn't blow up because of the voltage, because it's an American system.
Okay. So
Mhm.
Gifty, does that answer your question, or you still had a question? I see your hand is up.
Probably
Oh,
didn't.
I have to push the button to lower it. But yes, it does answer my question. And if you do plan on going to Ghana, I would love to
Of
tag
course.
along.
Of
So
course,
I'll be
of
reaching
course.
out to you.
Yep, of course. Because
Thank you.
we always can find funding for stuff like that.
That's right. Thank you.
Mhm.
Is Gifty your mentee?
No, I don't even know her. I think she said she was at Hopkins.
Oh, okay.
So you must know what's his name, Dr. John. He goes to Africa quite a lot.
Yes, Dr. Sampson.
Yes.
Yeah.
Dr. Sampson, good friend of mine.
Well, thank you so much, Dr. Wright.
Of course.
All right, so this has been wonderful. We're just at the top of the hour. We want to thank all of you for joining us. And the nice thing is, those who thought it was procedures for the elderly and so didn't come and listen, at least we have the YouTube link, and I think people would do well to go back and watch it. And so on this note, I'd like to thank you, Dr. Wright, for taking the
Of
time.
course.
I know it was a very incredibly busy day, surgery, etc., but making the
That's okay.
time to
No, it was a pleasure, definitely a pleasure to do
right,
this.
right. And
Honored to do it.
UPSF is very delighted that you are a staunch member,
Mhm.
and thank you for all your contributions. And I like to remind people that our annual conference is coming live in Washington, DC. And our DMV chapter is going to be very instrumental in making sure it's a huge success. So please go ahead and register. There's so much information on all your platforms. And this week, so February 4th, the Atlanta chapter is also having an event, I believe at 4 p.m. So if you know somebody in the Atlanta area, please encourage them to join. And I know February 25th, the DMV chapter is also having a meeting. They meet quite often, or they have met quite often in the past. So please endeavor to be part of it. So this has been a GPSF Ghana Physicians and Surgeons Foundation event with Dr. Thelma Wright talking about interventional procedures for managing pain. And it's not just in the elderly. Oh, I had one question, but I suppose it can wait. I wondered why you only deal with chronic pain and not acute pain.
Yeah, I did acute, but I got out of that space.
Okay.
Yeah, especially because I think I was needed more in chronic. I used to be the director of the acute pain at university, but the university is separate from where the clinic is. So I would have to go and round on the acute pain patients and then come to clinic, and it was getting a bit burdensome. So I told my boss, no, I can't do this anymore.
Okay.
So we pulled out of that, but we still cover the weekends.
Okay.
So, the chronic pain patients, doctors cover the weekend.
Okay. All right. Well, thank you very much. And you all have a wonderful weekend.
All right, you too.
And see you at the conference in person.
All right, take care.
Okay, bye-bye.